Welcome to GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis.
Dermoscopy. Think A to G. Our specialist is Dr. Alison Buckley.
Asymmetry. One of the key distinguishing factors between benign nevi and melanoma is symmetry of the lesion. Benign nevi tend to be symmetrical. If you were to draw a line through the lesion, through either pole, then the two halves of the lesion should match, both in colour and in structure. And benign nevi tend to have single colour or two colours. If it's two colours, then it should be symmetrical throughout the lesion. However, with melanoma, we tend to see asymmetry. That can be in structure, dermoscopically or macroscopically, or colour or border. If we see asymmetry in a lesion, we should immediately be suspicious that this could be a melanoma. Border. Another important feature to look at to help distinguish between benign nevi and melanoma is the border. With benign nevi, we tend to see a regular border both in terms of structure and pigment network. Benign lesions tend to have the deeper pigment network centrally, and this fades peripherally, symmetrically throughout the lesion. With melanoma, the border may be irregular, both in terms of colour and structure. Dermoscopically, we may see branching lines, streaks, or globules towards the periphery. We may see an altered pigment network, but there will be an irregular border. Macroscopically, this may appear scalloped or notched. So if you see an irregular border on a lesion, be suspicious that this could be melanoma. Colour. Another important feature that helps us differentiate benign nevi from melanoma is the colour of the lesion. Most benign nevi are one colour, usually light tan or brown, whereas melanoma may be multiple colours. This represents melanocytes at different levels in the skin. Melanocytes in the epidermis usually appear dark brown or black. At the dermoepidermal junction, where most nevi arise from, the colour is usually brown. And if the lesion arises from the dermis, then the colour will be blue or grey. This explains why we may see multiple colours in melanoma. Remember that there are also hypomelanotic or amelanotic melanoma, which may simply appear as red lesions. Beware of the red lesion that cannot be clearly identified as a benign lesion. Dermoscopic features. Dermoscopy is invaluable in helping us to differentiate benign nevi from melanoma. With benign nevi, there tends to be a prominent network pattern throughout the lesion, commonly reticular or globular, depending on the age of the patient. With melanoma, we may start to see multi-component patterns, which are spread erratically throughout the lesion. We may see blue-white structures, and we may see abnormal vascular structures. The more chaotic a lesion is in terms of structure, the more we should think that this may be a melanoma. Chaos equals cancer. Evolution. Any history of change in size, shape, or colour of a lesion should arouse suspicion that this may be a melanoma. This may be noted clinically by the patient or by the clinician. Dermoscopy helps us to monitor these changes more accurately, and any change in evolving lesion seen on dermoscopy should make us aware that this may be a melanoma. Changes that we may particularly see are thickening of pigment network in certain places and development of globules or streaks, especially peripherally. These represent growth of a lesion. So any evolution of a lesion, be suspicious that this may be a melanoma. Featureless. Be aware that some melanoma are featureless. If at the end of our examination we cannot clearly identify a lesion as benign, such as a seborrheic keratosis or a dermatofibroma, or a benign nevus, because there are no clearly identifying signs on dermoscopy, then we should assume that this may be a structureless melanoma and refer on a 2-week wait for histology. Global pattern. In dermoscopy, the global pattern refers to the predominant pigment network seen throughout a lesion. In benign lesions, this tends to be a single pattern that we would see throughout the lesion, particularly reticular, homogeneous, or globular patterns. In melanoma, we start to see more than one pattern. which may be a mixture of reticular, globular, or homogeneous, or areas of blue-white veil. The more patterns we see in a lesion, the more concerned we should be that this may be a melanoma. So certainly if there are multi-component lesions with more than 2 or 3 patterns, or homogeneous areas or non-specific areas that don't fit into the pattern we recognise as benign, then be suspicious that this could be melanoma. In acral sites, we tend to see a parallel pattern. In benign lesions, this is in the furrows, whereas in melanoma, we see the predominant pigment pattern is in the ridges. Asymmetry, border, colour, dermoscopic features, evolution, featureless, global pattern.
GatewayC Live, Greater Manchester. Facts. Supporting earlier and faster cancer diagnosis.